Good evening. I'm Dr. DrChebli. Welcome to our seminar. I think it's always helpful before we start for me to give you a little background personal information about myself and make sure you know that there'll be plenty of opportunity after we're done to take questions about both my personal background as well as the information in the seminar. So I was born in Canton, Ohio, which is where the Pro Football Hall of Fame is. I was raised in New York City, in Staten Island, New York. From there, I attended college at Georgetown University in Washington, D.C. I then went on to medical school at State University of New York, Stony Brook, which is in Long Island, New York. And then went to back to Georgetown for my surgical residency, which I completed in 2001 at Georgetown University Hospital in Washington, D.C. I went into private practice out of residency in Fairfax, Virginia, and was part of a very busy bariatric surgical program where I was lucky to be around a lot of good people. In 2005, my wife and I relocated here as my wife took a fellowship at University of Washington, and we moved there. We moved at the time with my one daughter, and I subsequently now have 3 daughters, all very young, and started a private practice in Seattle. Here in Seattle, for the first 7.5 years or so in this area, I was at a practice located between Northwest Hospital and Evergreen Hospital Medical Center, and I was the director of both facilities. And then in late 2012, I relocated my practice here and was very happy to become part of Overlake Hospital Medical Center. And I'm part of Overlake Metabolic and Bariatric Surgery, and I'm very happy to be here. So that's sort of how I got here. And again, any questions you have about my background or how I became interested in bariatric surgery, I'm happy to answer as we go on tonight. So thank you. I want to thank you for your attention in advance. And why don't we go ahead and get started with the scientific program. Tonight we're going to talk about the surgical management of morbid obesity. So in order to talk about obesity, we first have to classify it. And we use this terminology BMI, or body mass index. And body mass index is a ratio of one's weight in kilograms to one's height, which is converted into meters squared. So we subclassify the epidemic of obesity by this BMI in terms of levels. We consider BMI 25 and higher to be considered overweight, or we consider BMI to be over 25 to consider overweight. At a BMI of 30, we consider that obesity, or class 1 obesity. Class 2 obesity is considered a BMI between 35 and 40. Class 3 obesity is considered a BMI between 40 and 50. And class 4 obesity is a BMI over 50, or we call that supermorbid obesity. So what are the indications for surgery? Well, we defer to the National Institute of Health consensus statement on bariatric surgery from 1991. And that consensus statement defines morbid obesity and indication for surgery as a BMI more than 40 or a BMI more than 35 with at least one high-risk medical, what we call comorbidity. And a medical comorbidity can be defined as high blood pressure, type 2 diabetes, obstructive sleep apnea, or a lipid problem like high cholesterol or gastroesophageal reflux disease. We want to see that patients meet the following criteria to be considered for bariatric surgery. And that is that they failed some form of diet therapy, that those patients are psychologically stable, that they have some knowledge about surgery and its outcomes, that they're motivated to be successful with surgery, and that they have medical problems that do not preclude their likely success and survival from surgery. So there are 4 major worldwide treatments for morbid obesity surgically, and they're all done laparoscopically, which is minimally invasive surgery. And they are adjustable gastric banding, sleeve gastrectomy, gastric bypass, or biliopancreatic diversion with or without duodenal switch. So we'll talk about laparoscopic adjustable gastric bands first. And this is a photograph of a laparoscopic adjustable gastric band. This is the trademark lap band. Most people refer to this as lap banding. And so what you see here is a picture of the esophagus as it comes through the diaphragm and the band position just below the junction of the esophagus and stomach. So this is our society statement on adjustable gastric banding. I'll try to give you the society statement of each of these operations as we go along. Is that weight loss should be expected to be about 50% at 2 years, that the mortality of surgery is about 1 in 1,000, the morbidity of any other potential complications of surgery is about 5%. And there can be other long-term complications, and we'll discuss those in more detail shortly. The advantages of laparoscopic adjustable gastric banding are that it's a relatively simple procedure to perform. It has the lowest mortality rate of any bariatric surgery at about 1 in 1,000. And the advantage of the band and also the sleeve that we're going to talk about shortly is that they maintain the continuity of the GI tract. In other words, there's no intestinal manipulation or shortening or what some people refer to as rerouting. This is a procedure that, for the most part, can be performed as a same-day procedure or an overnight stay, and it has a very low incidence of short-term serious complications. Now, the disadvantage of laparoscopic adjustable gastric banding is that there's no alteration of metabolism. And very much these days we hear this talk of obesity as a metabolic problem or a metabolic disease. But the disadvantage of the band is that there's no alteration in metabolism. There's also statistical much higher failure rate with bands than the other procedures we're going to discuss. And there are long-term foreign body complications such as erosions and slip and problems with motility, which is problems in swallowing. There can be problems in pouch or esophageal dilation or expansion of the pouch above the band. And there can be tubing problems and there can be port access problems. And we know that statistically that bands are effective to a much lesser degree for obesity or supermorbid obesity. One notation that the band was recently approved for the lower BMI group, the class 1 obese group, between BMI and 30 to 35, with at least one high-risk comorbidity, and was FDA approved for this purpose. And only the lap band, the trademark lap band, is approved for this purpose. The other band, that's the realized band, does not have the FDA approval for this indication. And I have to mention that there is no long-term data with regard to this specific BMI subgroup. Okay, let's move on to the sleeve gastrectomy. You see a picture of the sleeve gastrectomy. That's the area colored in red. And the paler area you see in this slide is a picture of the part of the stomach that's removed in the sleeve gastrectomy. In the shaded colored area of the sleeve gastrectomy, some people would refer to this as a comma-shaped type of construction, or others refer to it as a half moon, and some refer to it as a banana-shaped reservoir. The area that you see in the paler part of the picture, which is a picture of the excise or the removed stomach, is the part of the stomach that we actually take out in the sleeve gastrectomy. And when we talk a little bit about the metabolic benefit of the sleeve later on, what we're talking about is this removed part of the stomach. This is where the hormone ghrelin that a lot of people talk about these days and ask us about, the so-called appetite hormone, resides. 85% of the body's ghrelin lives in this part of the stomach that we removed. And that's why the sleeve is such an effective surgery for controlling appetite. It's because of this ghrelin effect. So this is our society statement on the sleeve gastrectomy as far as most recent publication. And this is the summary from the 3rd annual consensus of the sleeve that was in December of 2010 in New York. The 4th annual consensus was just held in December of 2012, and those results haven't been published yet. But this talked about data from almost 300 surgeons worldwide who performed sleeve gastrectomy for a total of 27,000 sleeves, and an overall mortality rate that's published at 1.9 per 1,000. And the summary of this is that the sleeve is an effective procedure as a standalone surgery or as a staged procedure. So what are the advantages of the sleeve gastrectomy? It involves gastric restriction without the need for a foreign body, such as a band. The pylorus is preserved, so there's no dumping that happens with this procedure, similar to gastric bypass type operations. And it's a very useful procedure as a first stage surgery, which is the way the sleeve originally was intended for super obese or class 4 obese patients. And with the sleeve, as I mentioned earlier, the GI tract continuity is maintained so that there's, again, no need for intestinal reconstruction, as we talked about. And it is very much a metabolic surgery, so there is this change in metabolism that happens mostly as a function of removal of a portion of the stomach. And what you do when you remove that portion of the stomach is you remove the appetite hormone, ghrelin, which has a lot to do with one's appetite. And 85% of the body's ghrelin resides in that part of the stomach that's removed. What are the disadvantages of the sleeve gastrectomy? Well, we have to talk about some of the major complication risks. The leak rate of the sleeve is somewhere between 1.5 and 2.5%. The risk of bleeding that would require blood transfusion, so major bleeding episodes, 3%. Risk of mortality, as we discussed, 1.9 per 1,000. And we have to talk a little bit about heartburn, or GERD, which is gastroesophageal reflux disease. People who have severe reflux disease, this is a relative contraindication of the sleeve, so we have to proceed very cautiously in this patient group as far as reflux. And many of us consider Barrett's esophagus, which is a consequence of severe reflux, to be an absolute contraindication to proceeding with a sleeve gastrectomy. So it's very important that we get that information for the patient, and we are very good about getting that information for the patient when they're considering surgical options. This is the only operation that's truly irreversible. So once you remove that portion of the stomach, it cannot be put back in the patient. So this is an irreversible surgery. We see still with the sleeve gastrectomy, such as Medicare and other carriers, that there's still a relative lack of insurance participation with regard to the sleeve. And this is still why most patients don't have access to the sleeve, and why many surgeons don't have very large sleeve series, because of the lack of insurance participation or allowance for the patient to consider this type of procedure. And still with the sleeve, we tell all of our patients that we have good short and intermediate data, but we don't have quality long-term data with regard to the sleeve. Okay, next we're going to talk about the laparoscopic Roux-en-Y gastric bypass. And in this photograph, you see a picture of the small pouch, which is about the size of my thumb, and an intestinal reconstruction called a Roux-en-Y reconstruction. And this operation, according to our society, involves a weight loss of about 2/3 excess weight loss at about 1 year that follows surgery. We generally see that plateauing around 1 to 2 years that follows surgery. And these are older slides, remember, from Society Consensus, but at the time we were publishing mortality, at the time the consensus statements were made, the mortality was about 1 in 200 with laparoscopic Roux-en-Y gastric bypass, and the morbidity or potential for other complications cumulatively to be about 5%. So what are the advantages of gastric bypass? Well, we still consider it the gold standard surgery. And why do we say that? It's because people lose weight and rapidly, and it's a very effective weight loss operation, and also the resolution of the other medical problems or so-called comorbidities that we talked about earlier resolve to a very good extent and to the greatest extent with this operation. And this is very much a metabolic operation. Now, the benefit of the metabolic surgery and the bypass, and we talked a little bit about that in the sleeve, is that when you bypass that old stomach or excluded stomach in the gastric bypass, you get the ghrelin benefits you get with the sleeve gastrectomy. But you get the added benefit of the way that glucose is immediately transported away from that old stomach and into the small intestine that sets up a metabolic effect whereby people's diabetes improves at surgery. We call this the on-table remission of type 2 diabetes. And you hear a lot about this in the news. And what we're talking about is people leaving the hospital with their diabetes in remission, and that's before they lose any weight. This is the most exciting thing that we've learned to tell the medical community in the last few years. And this is a lot of the reason why we're excited here at Overlake to call ourselves Overlake Metabolic and Bariatric Surgery. This is the driving force of our practice, the resolution of type 2 diabetes, the resolution of these other medical problems, and the mechanism in which they occur. So the disadvantage of laparoscopic Roux-en-Y gastric bypass is leak, which is about 1% or less in experienced surgeons' hands, VTE means venous thromboembolism or blood clot issues, which is about 1 in 200. The risk of bleeding is about 2% in terms of requiring blood transfusion. The risk of obstructions, and these can happen early or late, at about 2% after surgery. And risk of mortality, which is more in line with what we tell people now from some of the data that we're going to go over, which is about 2 in 1,000 with this operation. But the malabsorptive component, the Roux-en-Y, the intestinal reconstruction part, is important to emphasize. And that means that people have to have permanent vitamin and mineral supplementation with this operation. And as a result, they need long-term follow-up, lifelong long-term follow-up. So next we're going to go on to the laparoscopic duodenal switch, and this is a picture of the duodenal switch operation. And what you see in this, and what you'll notice right away in this picture, is the top part, you see that banana shape or half moon reservoir, and that's the sleeve. That's where the sleeve came from. It came from laparoscopic duodenal switch surgeons who were performing DS, and those patients couldn't tolerate the full operation, or the idea of doing only the sleeve part for the patients and bringing them back when their anesthesia risk scores were much lower and they were healthier patients and lost some weight. So the top part of this slide that you see is the sleeve, and below it is a much longer type gastric bypass. And the mixing of the bile and the digestive fluids here happens with a much shorter, what we call common channel. So what does the society say about the duodenal switch? Is that it's a very effective operation for weight loss. And people lose about 70% of their excess weight loss with the duodenal switch operation. At the time this slide was written, the mortality was thought to be about 1 in 100 with this operation. But we now know that that number is also, as we've talked about in some of the other operations, is much lower. The overall morbidity or other problems that can happen with the operation is about 5%. So what are the advantages of the duodenal switch? Well, it's a superior operation statistically for super morbidly obese patients, and especially when you're talking about a BMI group with a BMI more than 55 or certainly has approached 60. This is an operation that we still talk to our patients obtaining more information about and potentially even considering a consultation with a surgeon who offers this. People lose weight very rapidly, similar to gastric bypass with duodenal switch. It has excellent statistical durability over time. And this is very much, just like we talked about with gastric bypass, a metabolic surgery and an operation that resolves medical comorbidities to a great extent. The disadvantage of the duodenal switch is mortality, leak rate, risk of bleeding, risk of blood clot, obstruction problems. But the big problem, and the reason why in the most recent scientific meeting that we had for the American Society of Metabolic and Bariatric Surgery and why we see it decreasing, and it was less than 1% of the B.O.L.D database at our recent meeting, is quality of life issues. This is an operation that's not performed by many surgeons. And every decade it's becoming less and less popular. And a lot of that has to do with quality of life issues, which can involve malodorous flatulence and bowel function for patients, or protein and vitamin deficiencies. So this is a slide just to give you an idea, a comparison study of 3 common bariatric surgeries with different authors from all over the world. And the take home of this slide is that there were a lot of studies that compared bypass and band and sleeve and gastric bypass. And the upshot of this slide as you look through the data is that what we see when you look at 1-year and 3-year data is that the bypass patients statistically outperform. And you also see that early on in comparability that bypass and sleeve patients tend to be similar, but we don't have a lot of long-term quality data with regard to the sleeve patients at this point. This is a perioperative safety study from what was called L.A.B.S, the Longitudinal Assessment of Bariatric Surgery. And it was a big deal at the time. It was published in the New England Journal of Medicine in July of 2009. And with about 5,000 patients who had first-time bariatric surgery, which really was the first study that showed that we could do bariatric surgery with a really acceptable low risk of mortality or death in the first 30 days. And in this study, there was a likelihood of death at about 1 in 333 patients at 30 days, showing that mortality data that we talked about earlier, it was really starting to come down at this period of time when this study was written. So the conclusion of this paper was that the overall risk of death and adverse outcome from bariatric surgery was quite low. and very acceptable. This is the B.O.L.D, or Bariatric Outcomes Longitudinal Database publication from 2010. And this was the first publication that looked at all the Center of Excellence data for Center of Excellence studies done in the US. And this detailed 60,000 patients who had the various bariatric surgeries that you see distributed. And this was between July 2007 and May 2009. The complication rate for these operations in Center of Excellence hospitals with Center of Excellence surgeons were gastric banding overall of about 4.6%, sleeve gastrectomy about 10%, gastric bypass about 15%, and biliopancreatic diversion duodenal switch at 25%. And interestingly enough, as we talked about in the most recent meeting, when those results were re-reviewed, the BPDDS patients were left out because they represented under 1% of the total patients, but they were included in this publication at this time. And mortality was about 1.3% overall from all the surgeries at overall in the series, and the 30-day mortality of under 1 in 1,000, which is remarkable. So you see that as time goes on, the surgery becomes safer and the mortality rate decreases. This is a life expectancy study done from Canada, done by an author named Christo, who looked at the 5-year death rate in patients who had surgery and those who did not have surgery. And in the looking at 5-year death rate in patients who had surgery, that was 0.68%, well under 1%, compared to 6% in patients who needed surgery but chose not to have it. And that's an 89% relative risk reduction with surgery compared to non-surgery, remarkable number. This is a study from Utah, published in New England Journal in 2007, that looked at a similar group, 8,000 patients who had gastric bypass and 8,000 patients who were compared who didn't have surgery. And what you saw in a follow-up period of about 7 years, and the overall mortality decreased by 40% in the patient group that had surgery compared to those that did not. And if you specifically looked at people and their medical problems, if you looked at the patients who had coronary artery disease, the overall mortality decreased by 56% in the gastric bypass patients compared to those patients who did not. Diabetes, reduction in mortality by 92% in the surgery group, and in patients who had a form of cancer, 60% mortality decrease in the gastric bypass patients compared to those who did not have surgery. This is a study that looked at a meta-analysis of bariatric surgery that was published in the Journal of American Medical Association in 2004, 23,000 overall patients who had bariatric surgery, and an overall mean excess weight loss of over 60%, putting all the surgery patients together. But the really fascinating thing was when you looked at what the patients did as far as their medical problems, the resolution of diabetes happened in 76.8% of patients. Lipid problems improved in 70%. High blood pressure resolved in over 60%. It resolved or improved in almost 80% of patients. And obstructive sleep apnea resolved or improved in about 85% of patients. This is a study that looked at weight and type 2 diabetes after bariatric surgery, just specifically looking at diabetes and bariatric surgery from the same author, looking at 103 studies, over 135,000 patients that detailed some results about diabetes and bariatric surgery, and the overall remission of diabetes was 78.1% of diabetic patients who experienced remission after bariatric surgery. Diabetes, if you look at improvement and include that, 86.6 improvement or remission of type 2 diabetes. And the summary of this paper was that weight loss and diabetes resolution were best for biliopancreatic diversion duodenal switch, followed by gastric bypass, followed by, gastric banding. So this is a study in Australia that compared adjustable gastric banding for type 2 diabetes to medical or non-surgical treatment. And the summary of this study is that if you looked at the 60 patients who had surgery, that were randomized, and you looked at the ones that had surgery and those that had medical treatment, remission of type 2 diabetes occurred in 73% of the patients who had bands, compared to 13% of the patients who had no surgery. Now, this was a very important publication that was published in multiple journals, Diabetic Medicine in 2011, by the International Diabetes Federation, and then in our obesity surgery journal, which is called the SWORD Journal. And this was the summary statement for obese treatment by surgery for type 2 diabetics. And the summary statement was that surgery should be an acceptable option in patients who have type 2 diabetes and a BMI over 35. And we should strongly start giving consideration to surgery for the BMI group between 30 and 35, especially when their diabetes can't be controlled by medical management, and especially those with cardiovascular disease. We also should take note of the summary statement that said that all the available evidence indicates that bariatric surgery is and has been shown to be cost effective for the treatment of type 2 diabetes. And that people should understand that morbidity and mortality with bariatric surgery is generally low, and it's comparable to a gallbladder surgery, which many of us consider an everyday surgery, both in the US and worldwide. So these are a couple important studies that were published recently, and they were both published in the New England Journal of Medicine just last year, that looked at, again, surgery for type 2 diabetes, comparing medical management and surgical management. And in this first study by Phil Schauer, they looked at gastric bypass and sleeve gastrectomy patients compared to medical patients, with an end target of hemoglobin A1C of 6% or less. And in this study, only 12% of the medical patients reached that endpoint. 42% of the gastric bypass patients reached that endpoint. 37% of the sleeve patients reached that endpoint. In another study done that compared medicine to gastric bypass to biliopancreatic diversion in the New England Journal, the same journal in last year, looking at the endpoint of fasting glucose less than 100 and an A1C less than 6.5%, medical therapy reaching endpoint at 2 years, 0%. Gastric bypass reaching endpoint 75%, and biliopancreatic diversion duodenal switch, 95% of the patients reaching that endpoint. So what is my overall surgical experience? I've done over 1,000 bariatric procedures in my career thus far, and this is the way they break down. The majority of my experience has been gastric bypass, 682 procedures, sleeve gastrectomy, 66, adjustable gastric bands, 155, and revision bariatric surgery, about 150 procedures. What are the bariatric surgical options in my hands, in my practice? I offer the laparoscopic adjustable gastric band, the laparoscopic sleeve gastrectomy, laparoscopic Roux-en-Y gastric bypass, and I also offer and perform revision bariatric surgery. So that concludes our seminar. As far as what the next steps would be, you can go back to the website. We would be happy to see any of you in a consultative appointment in the office. The office number is provided, as you see, and you could just call the office and set up a consultation and let the office know that you were here in a seminar. As far as additional information in your seminar packet that you've received, there's a copy of my most recent few publications. That's a nice resource for additional information. Our bariatric program coordinator, Carmela Pontillo, is at your disposal also for any programmatic questions that you have. Any questions really at all, you're more than welcome to go back and discuss what we discussed here tonight in more detail with your primary care physician, or I'm happy to discuss things in more detail with your primary care physician. But anyway, the bottom line really is any questions, confusions, additional information, you can be more than happy to reach out to the office, and we'll be happy to provide you more information, or visit the website for more multimedia education or anything to that extent. But I certainly want to take this opportunity to tell you how happy we are to have had you attended, and certainly for your attention, coming in the evening after work. And I thank you very much. And I certainly want to open it up now to any questions that anybody in the group has. Thank you.